Okay, today I have chosen one more PYT of surgery, that is Gerd and Barrett's esophagus. We'll quickly go through this topic, and whatever stuff is important for examination point of view, we'll cover that. Okay, so first of all, we'll get an idea what exactly is GERD. This is gastroesophageal reflux disease. So what is happening here? So acid from the stomach is going back into the esophagus. This is the reflux. This is exactly the meaning of reflux. And why is this happening? Because either too much pressure pushing up, or too little barrier stopping it. So this can be the reason. So first of all, we'll discuss about the factors which are maintaining this lower esophageal sphincter patency. Okay, so to remember this four points, we'll remember it with the mnemonic safe in the lap of these protective factors. Okay, so if they like these all four are the protective factors. Lap in Hindi we call god, lap. Okay, so first L is length of the intra-abdominal esophagus, which is the most important factor for maintaining this LES patency. Normally it should be between 3 to 5 centimeter. If it is less than 2 centimeter, there is this predisposition to GERD. Next A is, we can say, like initially we started with this most important. Now we can focus for least important. Okay, arrangement of mucosal folds. Then other A is angle of his is orientation of gastroesophageal junction, and P is pinching effect of what? Right diaphragmatic crura. Okay, one more thing we have to remember, that if this LES pressure is less than 6 mm of Hg, it can predispose to it can lead to GERD. Okay, now we'll discuss about the various predisposing factors which are responsible for GERD. So first is this increased transient LES relaxation, which is the earliest physiological indicator. So what is happening here? So LES, we know that this lower esophageal sphincter, exactly what it is. This is the valve between both the esophagus and the stomach. So normally it stays shut. It stays shut. So what is happening in GERD? The valve often relaxes too often. The valve relaxes too often, and that letting the acid escape. Okay, so we can think of it like a door that keeps swinging open randomly when it should stay shut. Okay, so this is the earliest physiological indicator, marker indicator. Okay, so next thing we have this obesity. We'll discuss about this central obesity. Okay, central obesity, we can say it like big tummy fat. So what is happening here? So big tummy ka matlab that there will be increased pressure on the stomach, that will lead to acid forced upward. Okay, that leads to that acid will forced upward. And also one more thing we see in obese people, this is factual knowledge, that they have less H. pylori infection rate. Okay, less H. pylori infection rate, due to which what is happening, this is a bacteria that ironically sometimes protects against GERD. So this is protective for GERD. So obese people are not getting often this infection, so they have more chances for GERD because H. pylori infection is protective. Now one more thing we have to remember, that for central obesity, it can lead to this Barrett's. There is increased risk of Barrett's esophagus and adenocarcinoma. So why is this happening? Because of the constant reflux that can damage the esophagus lining. So over time it changes into Barrett's esophagus, which is the precancerous condition, and that increase the risk of adenocarcinoma, which is the cancer. So this way we can remember this. Now we'll discuss about the clinical features. So first and most important is heartburn. So which is this retrosternal burning and water breath, like patient can say like khatta pani banna in like patient's language. Pharyngitis, laryngitis, chronic cough, wheezing, and dental caries can all be the clinical features. Now we'll discuss about the investigation. The investigation of choice here is endoscopy. Initially we'll go inside and see what is happening inside the esophagus. The whole issue is there. So investigation of choice will say, okay, endoscopy, but gold standard ka we have to remember. Gold, okay, 4 letter. GERD, again 4 letter. Gold is, I think, a 24 karat gold. Okay, okay. GERD is also 24. Okay, 24 to 24 word is also common for both. So 24-hour pH monitoring is done here. Okay, this is the gold standard. This is gold standard 24 wala. So how do we manage it? So stepwise management. Lifestyle, first we'll advise the patient to change his lifestyle. Like we'll advise him for weight reduction, small frequent meals, and will advise him like last meal should be more than equal to 3 hours before going to bed. Medical treatment may we can give him PPIs, prokinetics, and sometimes we may need a surgical intervention. That we do is fundoplication. This is important. Okay, for fundoplication, first of all, like we don't do it in every patient. So what are the indications where we are doing this fundoplication? So those patients who are not responding to medical treatment and those having complications of GERD, and if GERD is presented with large hiatal hernia, we remember that we did last time, that was sliding and rolling. Rolling was always surgical management, and sliding may only if it is large and symptomatic, then only we do surgery. So large hiatal hernia plus GERD, we go for fundoplication, and those patient who wants to stop the medical treatment. So what is the principle behind this surgery? So we have to restore all those lap wale protective factors. We have to restore, we have to bring them back, we have to correct them. So basically we'll restore the adequate intra-abdominal length, will tighten the diaphragmatic crura, will wrap the fundus around esophagus, will preserve the biggest nerves and re-establish angle of his. So we'll discuss about all the types. Okay, types of fundoplication. So first is this complete wrap. Complete wrap. This is the complete wrap. Okay, so here, like, what is this fundoplication? This is like the fundus is like a scarf around this esophagus. Okay, we're tying a scarf around the esophagus. So this way we can remember, like, this is a scarf around this esophagus to maintain that patency. Okay, so first is the complete mate is Nissen. So Nissen 360 degree na. So there is no space. So Nissen's ka we can remember it like nil space. And the most common complication with this is gas blot syndrome. This is important. And now we have is this partial wraps which prevents this gas blot, which is with complete wrap. So first is this anterior, then we have Toppet and Velsey mark. So how to remember this? Okay, door ka we can remember, like out of all these three, only one has P in their name. So this one is only posterior, rest both are anterior. This way we have done. Door is like I'm just standing in front of a door. Okay, I'm standing in front of a door. So door, like door is straight, right, 180 degree. Okay, so 180 degree front of door. Okay, so anteriorly. Toppet ka has P in the name, so it is 180, 270. And Welsh ka is like Welsh ka we can almost full, but only from the, like, but only from the front, like only from the front is, it's like 3/4. It's like 3/4, and this is where we can remember it. Okay, so now we have, this is okay, 270, 180, 180 to 270, and then we have 270. Okay, so then we have this Colles gastroplasty. So what is this Colles gastroplasty? So we have to remember, this is like we are creating a new esophagus. So we are actually trying to increase the length by more than 3 centimeter. And we have also newer modalities which we can discuss, like polymer injection, but it has higher recurrence. Endoscopic radiofrequency ablation has good long-term results. Then we have one more modality, LINX links, which there is this magnetic sphincter augmentation. Tempo trial is this transoral incisionless endoscopic fundoplication. So now we have one more topic here, this complication of I think okay, this is the complication of GERD. So this is Barrett's esophagus. So here what is happening, there is this intestinal metaplasia. So now the columnar lined esophagus replacing the normal squamous. Okay, this columnar is normally present in the stomach intestine, but now it is covering the esophagus. Okay, now we'll see, there will be intestinal metaplasia, we'll see the goblet cells also there. And types can be short and long segment. If it is more than 3 centimeter, we'll consider it as long, and we know that it increases the risk of adenocarcinoma. So we can remember it like A and B, both are like together. Okay, so not SCC but adenocarcinoma. Now clinical scenario mein, like any patient will come to us like GERD history, endoscopy may we can see. Okay, when we read this, endoscopy was what, that was the investigation of choice. GERD mein history mein what we did, like how will patient heartburn, okay, water brush, pharyngitis, laryngitis, all these things. And endoscopy we can see this intestinal metaplasia plus minus dysplasia. And high grade, if this is the like potential questions, if there is this high grade dysplasia, the best treatment is radio frequency ablation. If there is low grade dysplasia or intestinal metaplasia only, we just go for GERD management, GERD treatment and endoscopic surveillance. Okay, and esophagectomy only if there is invasive carcinoma. So here we have to remember the buzzwords. Now LES length, if lower esophageal sphincter length is less than 2 centimeter, we know it can lead to GERD. If pressure is less than 6, okay, then again GERD. There will be central obesity that can lead to ultimately Barrett's. We read like how the central obesity can lead to GERD, then GERD can lead to Barrett, and Barrett can ultimately lead to adenocarcinoma. Investigation of choice, endoscopy, we can see also for GERD, we can also see this intestinal for this Barrett's we can see this intestinal metaplasia, and this is also investigation of choice in case of GERD. Gold standard is this gold GERD 24 carat 24-hour pH. Okay, Nissen is like nil space. So the what is the complication? This gas blot syndrome. Other partial labs, we have door 180 anterior, Toppet posterior 180 270, and Balse is almost best. Okay, so it is 270 but anterior. Okay, so Colles gastroplasty, here we are creating a new esophagus, so we are lengthening more than equal to 3 centimeters. We are trying to increase the length by more than equal to 3 centimeter. Barrett may we have to remember, we can see goblet cells, intestinal metaplasia. When it is more than 3 centimeter, there can be risk for adenocarcinoma. And in case of high grade dysplasia, if like there is this high grade dysplasia, then we'll go with radio frequency ablation. This is important point. Okay, I think this is enough for this topic, and with this we can answer any question from this topic. Okay, thank you.